you all here for I think the 11th time. And we're making progress in getting hepatitis B cure with ups and downs. And in my talk, which has some overlap, I must say, with what Ed just said, I'll focus a little bit more on the sustainability of the response of the S loss, because I think we're able to get patients into functional cure and get them into HBsAg loss. The multi-million-dollar question, however, is, can we keep them into HBsAg loss, or will we be confronted with more and more S0 reversions? These are my disclosures from the last 2 years, and I kind of cut my talk into 2 parts: so the treatment endpoints and HBV biomarkers, and then focus a little bit more on the sustainability of S-antigen loss. And actually, we had this talk, invited someone else to give it. He couldn't come, so I think, well, I'll just do it. But it is a challenge, I can tell you, and I hope that you'll learn something from me. So what about the treatment endpoints? This is all well known to you: functional cure, sustainable S-antigen loss, and HBV DNA undetectability for at least 24 weeks. And the question is, when should we assess it, really? Because there are a couple of compounds out there with a carryover effect, so like a washout period, and some people say we should look even later. I would say in general, it would be good not only to look after half a year, but after a year and even longer as well, to see to what extent our S losses, our functional cures, are truly sustained. So if you look at the biomarkers, there's many of them out of there. I won't give a lot of detail, just 1 or 2 slides on it. So the Quant S, as Ed already mentioned, is by far, I think, the most important one to be used. It should be available for the drugs to come also in the US. I hope they're making progress there. Bob Gish and others have been very active to do that. Around the globe elsewhere, I think you can get it done mostly. Then there's HBV RNA correlated antigen. I'll touch on 1 slide this afternoon. Mark Zulkowski will talk more on that as well. They're the isoforms where we really think that they might be somehow indicative of distinguishing integrated S coming from integrated DNA versus pre-genomic RNA. And then there are obviously the immunological biomarkers, and that's where we really need some work to be done, because we're lacking those. They're very difficult to develop, I would say. They're very volatile on a lot of processes happening in the body. But if we would have a better immunological biomarker, I think we could make much more progress in our adventures to get hepatitis B cured. So S quantification, it's well known. It is indicative at a lower level to distinguish truly inactive E-negative disease from active E-antigen negative disease. It's been a predictor for PEG interferon and nucleoside analog withdrawal. The problem that it's partly, particularly in E-negative patients, largely driven by integrated DNA. The novel biomarkers, just summarizing in 1 slide, I think they have a value to differentiate between the different phases of hepatitis B, the different phenotypes. More directly reflective of transcriptionally active cccDNA. However, the standardization and the validation is needed, and the particular problem is that the sensitivity of these assays are insufficient, in my view, yet to really help us moving towards functional cure. If you look, for instance, at E-negative patients on treatment, 40–50% of those patients is already HBV RNA or correlated antigen negative before you would even start with a new investigative compound, a new compound trying to cure. If you look at these biomarkers, they move over time, and the interesting part is in the different phase that even if you're S-antigen negative, correlated antigen HBV RNA might be positive in a small percentage of the patients. So the question is to what extent these biomarkers can really help us out. Just 1 slide on the truly more sensitive assays, and there are several out there. This is about the ITACT correlated antigen and S antigen. And in the lower part of the slide, you see that once you have an S antigen seroconversion, that these markers still remain to be positive over time. So they would be more sensitive, because we really need, I think, a better tools for cure and maybe also for sustainable cure to measure in that very low area of S antigen and I would say biomarkers indicative of active cccDNA. The last slide I have on the biomarkers is the use of fine needle aspirates, and we have a whole session on that after the break, but I think there might be a future in there, and we've been doing it for a long time, both in Rotterdam as well as in Toronto, and with modern techniques you can do a lot of interesting things, both on the virological side, where Maura Dandri and Barbara Testoni from Hamburg and Lyon have done a lot of work on, but in particular also on the immunological side. So more to come after the break, I would say. So what if we look at the sustainability of S loss with licensed and novel therapy? And a lot of people don't read papers that are older than 10 years. So I thought it'd be good to pull back these actually, in my view, pretty well performed studies at the time on PEG interferon monotherapy, and just to see what are what the level is that we have reached thus far with licensed compounds to get S antigen loss, and most of that also sustained S antigen loss. So if you give a year of PEG interferon, you roughly get 3 to 7% S loss after 6 months post-treatment follow-up with the different interferons that we had at the time, both in E negative as well as in E positive patients. And if you look, and this is studies that we did, and Patrick Marcelin did, if you look 3 to 4 years later on over time with sustained, with prolonged off-treatment follow-up, you get exactly the same figure of around 11% S antigen loss, both for E positive and E negative disease, if you give a year of interferon. So that's going up very slowly. A year of interferon is not a very nice thing to have. And the prediction for S loss is, in particular for E positive patients, genotype A is by far the most important predictor. There are yet very few genotype A patients around the globe. Well, there are certain parts of the world, I should say that, definitely, in Africa. And we had a lot of, actually in Europe, a lot of patients from Eastern Europe with genotype A at the time, from Poland in particular. Low HBV DNA, low S antigen, and the ALT is high as well. Because if we treat patients who are treatment naive, I would say E positive patients with high ALT values are very, very immune primed, and those are patients that might be easy to get, or easier to get into S loss at a certain time point as well. This is a later study done by Patrick Marcelin, and it's a well-performed study combining tenofovir with PEG interferon. And in the top, you can see in the blue line over, does this work or not? In the blue line, you see that there is, no, it doesn't work. There is 9% S antigen loss, which is incredibly high, I would say. The problem with this study, unlike many other studies with interferon, is that there are HBs antigen seroreversions. So there were patients who were S antigen negative and then kind of flip-flopped between S positivity and S negativity. So this Kaplan-Meier curve is actually not the way you should present these data, in my view. But in any case, and also here genotype A and the use of PEG interferon were the most important predictive factors of response. If you look at just giving a nuke, for those of you who were not aware about this, it is very, very low S loss rate. So this is, we're talking about finite treatment in any way, but after 5 to 8 years of TAF treatment with the latest studies, you don't get more than 1 to 2% S loss. And some studies it's a little bit higher, but that's definitely not the way to go. then another way to try to get functional cure with licensed therapy is just to stop the nukes. And there have been a lot of studies done. This is a study that we published, Keshmai wrote from the time with the Toronto group and actually a larger international consortium. So over time, it would give you roughly 13% S antigen loss. But this is, mind you, 48 weeks. So that's 4 years of follow-up, which is very slow and really too slow, I would say, to get anything done in our era of getting responses quickly, which the stockholders want and the companies want. So I think it's not good to rely on those data as treatment withdrawal as an additional, I would say, intervention in our treatment schedules for HBV cure. I would say, and it is very slow, but it is sustained in most of the patients. So the thing is, if you kind of summarize the sustainability of S loss in the natural history of the disease, it's very much sustained in most patients. With PEG interferon, it is. If it happens with a nuke, doesn't happen very often, but it's also sustained in here as well. So, and these are all slow processes. And the question is, why is it not so much sustained with, as I'll show you in a minute, with the new compounds that we're using? So I'm moving now to the trials that we're doing with both antivirals as well as immune modulatory agents in trying to get HBV cure. And if you look at we've been working on this now for, 10, 15 years. The first 7, 8 years for sure, all of the companies focused on antivirals in RNA interference or other mechanisms of actions, and that hasn't done the job. So for good reasons, many of them started to introduce immune modulatory agents in addition to their antivirals, and we have now for a couple of years some interesting data. I think that will help us go further. This is the study from MF published in the New England just on an antisense oligonucleotide. Ed has already alluded to it. What you see, for instance, in the left upper corner is that you're up to S antigen loss of 26%, which is, I mean, more than we've ever seen in the 30 years that I've worked in this field. So that's a spectacular result, really, that we should be very proud of. Yet, over time, off treatment, it's kind of fading back to only 12%. And you never know what's going to happen with even more prolonged follow-up. I really hope it won't go back to 0%, because then we would be in trouble. This is the zilnizumab, so the Roche compound, also alluded to by Ed already, which is an siRNA that was combined with the TLR7 agonist as well as with PEG interferon. And as you see here, combination with these immune modulatory compounds did do best. And I've been advocating kind of for reintroducing PEG interferon into our schedules, and particularly here in the US that wasn't really received very well, because this is very toxic, and it's not an easy drug to work with, but it's around for 30 years. We know its safety profile. We know how to deal with that. It's very cheap and it's around. So I think it's good that we're doing this study. And if we could use PEG interferon for 12, 24, maximum 48 weeks to get a better result, I think it's worthwhile to move on with that. Here also the problem, though, despite the fact that PEG interferon is introduced, is that the S antigen loss rate moves back from around 30% to 17% with a 1-year follow-up time. So what's going on? This is another study where, again, combining with longer PEG interferon treatment would give you the highest response rate of up to 25%. Whereas if you give here a VIR-2218 with a very short interferon course or just by itself, the responses are very low and you don't even reach S antigen loss. This has also been shown, and the question is to what extent anti-S would protect people from getting a relapse, so an S seroreversion, and we really don't know. This is a very small study. suggesting that if you have a higher anti-S level, that you'll be less prone to get a relapse. We don't know. Definitely with the other compounds, with PEG interferon or with nuke withdrawal, S loss by itself is pretty much sustained, and many of these patients over time develop anti-S. So for there, you don't really need a lot of anti-S to be developed to have it sustained, and it's a process over time that will come in, this production of anti-S. And it's also a question of the balance. Is if you don't kind of reduce the viral load, and if you take away your antiviral compound, S levels will go down, or S levels will go up again after discontinuation, and then anti-S becomes negative again. So I'm not sure yet that anti-S by itself is a good lock on the door to prevent relapses of disease. So how to increase our sustained S loss? We have to know which compounds to use, when to combine it, lead in or reduce HBV antigen burden, what duration of treatment is needed, fixed or response guided, and above all, what duration of follow-up we should have, and what will be the effect of nucleoside analog withdrawal, because many of our trials are done in nucleoside analog treated patients, and at one point in time we would have to take that drug away as well. Another way to success, I think, is to target the population, and we had hoped for a big success, but our progress has been slow. We have to admit that. So as I've always said, it's better to go from first base to second to third to fourth, to have a run rather than to try a home run all at once. And I think if we do adaptive enrichment and prognostic enrichment of our patient population, and first start with the patients which are most likely to respond, and Ed also talked extensively about that, which for our compounds is particularly low S levels, but maybe also young E-positive patients with active disease, I think we at least can get some of the drugs licensed, and from there we can move on and expand our treatment possibilities, get better individualized treatment, and get more compounds licensed over time. So if you look at the number of patients, this is a different analysis than Ed has done, but if we looked also in our own big databases, how many of these patients have an S level lower than 1,000? And if you look, for instance, in the RETRACT study where the treatment was stopped, it was 70%. In the CREATE study published by Milan Sonneveld, it was 54%. In the REVEAL study, it was 41%. So there are a lot of patients out there with these low S antigen levels. And for instance, in my practice, 85% of my patients are E antigen negative. So most of our patients are aging and then become more E antigen negative and get low S antigen levels. So I think there's a lot of work to do, and we have all of these patients in our hands in many, like hundreds of thousands of patients around the globe in all kinds of different clinics. So it would not be unwise to start with those patients. Would that be a full guarantee that you don't get a relapse? I don't know, but my hypothesis still is if you start with a lot of patients likely to get S loss, you also hopefully end up with more patients having a sustained S loss. And the other question is, do we need S antigen loss at all? So should we not rephrase our endpoint? And there's been some discussions, and we've had meetings, endpoint meetings, where we said we put the bar very high at S loss, but I think we have to look at partial cure as a secondary endpoint very carefully in our studies. Because as I've mentioned, these patients could come from integrated HBV DNA, and if you would be E negative, HBV DNA negative, off treatment for a long time, HBV RNA correlated antigen undetectable, would it matter to have an S level of around 10 or 15 or 20 if patients have a quiescent disease with normal ALT? I'm not so sure. So it could be also something that we have to look into, and then we would have to talk with the regulators, which will not be easy, but still I think we should look at that. So I'm coming to the end of my talk, I think. So functional cure if sustained, is the best guarantee for outcome. I didn't show the data, but there's less cirrhosis, HCC, and death. S loss is mostly sustained when it occurs spontaneously or with PEG interferon with nukes or with nuke withdrawal. Target engagement of new drugs can obviously be the viral life cycle of the immune system. We have to combine that, it's well known. Development of anti-S and B cell function. It would be good to talk also with the immunology on the B cell function and the value of producing antibodies. Maybe more important than we think, but we need more data. Currently, there is a considerable S antigen seroreversion rate, even with novel combination compounds. If we combine it with PEG interferon, how many will eventually remain S negative and anti-S positive? We don't know. We need more prolonged follow-up. I think initially we should, as we're doing, treat low-hanging fruit, those with low S levels. There are many out there. Once we are more successful, we could individualize. 6 to 12 months of treatment might be too short, I can tell you, and 6 to 12 months of post-treatment follow-up might also be too short. We should be cognizant of the carryover effect of drugs, and we need better biomarkers. And we should study the outcome of those with strictly defined partial cure, and remaining S production could just be from integrated DNA. I don't have any boats, but I just have the Erasmus MC Medical Center where I'm working. I thank you very much for your attention.